Ermal. Oh, is the wrong name there. This is Jürgen. Oh, we got.
Hey, Jürgen, how's it going, Ermali? I'm testing out the link. Can you hear me?
Yep, I can hear you.
Oh, good. Migena, good to see you.
Hey. How's everyone?
So far, so good.
Good.
You look busy, Dr. Bojdani.
Yeah, I'm doing a night shift. So, you know, I'll be able to stay on for a little bit at the beginning, and then I got to go because there are a lot of patients to be seen.
Okay, well, you better stay at the beginning. Okay.
Let's help with the start. Hold on.
So, I was going to ask you again because he's going to introduce us. So, you're again. What, so you're gonna, how does this go? I haven't been to one of these before. Tell us.
Sure. So actually, usually the introductions are done by Nora, but since Nora's not going to be here today, the introductions will be done by Laurent. So basically, he do the introductions, and then whoever is doing the presentation, basically, he'll introduce them.
Okay.
And like they'll start talking. So who's doing the presentation?
Migena, Dr. Dervishi.
Soon to be. Well, not yet, but will be.
Okay, I got you. So, yeah.
Okay.
So what I'm gonna do, like after we start the introductions, like I will share the screen, right? So you'll be able to basically like share your screen, so everyone can see your screen.
Wait, you share my screen or you give me the ability to share?
Right, so like I will give you the ability to share your screen.
Got it, okay. I was like, I don't know that option, but okay.
Yes, I mean, we just do it that way so people like don't go wild sharing nonsense, and so.
Yes, absolutely.
So yes, so as people join, they will all be muted. And then like as you start your presentation, I'll mute everyone again.
Good.
And then if they have any questions, like they'll be able to write them in the chat box. And then at the end of the presentation, then is when we'll open to answer questions as well as basically have like an open floor for
open floor, okay.
Open floor.
Dr. Bojdani, do you plan to join on those Q&A session, or should we just? I'll Google them. I mean, if I don't know them, I'll just.
I mean, I can join. Just because it's. I just have to maybe if we think about sort of what time that's going to happen, like how long do you think your presentation is going to go? For like about 30 minutes or something?
Yeah. Yes. 30 minutes tops, so I have like time myself. I will not go longer than 30 minutes.
Yeah. Good. So basically what we'll do is, I'll be at the beginning for the intro, then I'll just turn the screen off and let it run, and then I'll come back in about 30 minutes and we can field any questions. I mean, the nice thing is, from what I gather, there'll be other people who have experiences in these settings. So, just throw the question back at the podium, at the room and say, what do you guys think, So don't like, and at the end of the day, if we don't know a question, you say, we'll look it up. You look it up and tell us, stuff like that. Don't worry about it.
Okay.
Yeah.
I mean, I was going to say, so at the Journal Club, Sarah will be there as well. And Sarah and Laurent, actually, he's right here. Like he's going to join us right now. So, so he's right there. Let me see. He is about to connect.
Yeah.
There we go. Okay. So Laurent is also connected. So he's very good with like continuing conversations. So like if it gets a little bit.
Good. Yeah.
Hello,
hey guys.
Hello, Laurent. How's it going?
Hi guys. Good. How you guys doing?
Oh, good.
I'm nervous. Okay, like
yes.
We got our big blood. We're not nervous, puppy.
Don't be nervous. It's going to be very straightforward. I'm going to take a minute or two to just introduce you guys, the article and all that. But, you've done this a million times, just like when you do it when you're in residency and all that. And, we're going to hopefully, if anybody has any questions and stuff like that, they'll be at the end. You'll see, you'll like it. We've done it a few times already.
Yeah.
It's entertaining.
Yeah, just to update you, because we were talking before you joined in. So, because I'm at work right now and I got to handle some issues. So I'm going to stay for a few minutes at the beginning for the introduction. And then Migena intends to take about 30 minutes presenting. And then I will join for the Q&A in about 30 minutes. So just as an FYI, okay?
That should be fine. And it's actually a good thing you mentioned it, because I'm going to be signing off after about 15 minutes as well. Because I'm driving on my way to a conference.
Good
so
for you.
I'm going to do the introduction, and it's kind of random. I had to stop on the side of the road so we can do this. But
I see you got the car there. I see the car.
Yeah, you can see in the back.
Difficult conditions.
It's fine, and it's good because we want to make sure that you guys get the right introduction and the appropriate presentation. So thank you so much for taking the time. By the way, I really appreciate you guys taking time out of your busy schedule to do this.
Oh, no problem.
It does matter, not just to us obviously, but to the community that we have, and we have quite a few people signing up for the Journal Club, but also for this one, and it's becoming busier and busier every time we do it. More and more people are signing up because more people are hearing about it. And all the feedback we've gotten so far from members and from people who are not even members, but are, signing up for the talks has been excellent. They love the presentations. They learn a lot. They want more. So thank you guys for doing this, and we're going to ask you to do some more later in the future.
I think the benefit of this, guys, is that as the new generation, we're also getting to know each other and starting to build relationships and collaborations. Because one patient likely sees all of us at some point in their journey. So
absolutely,
I think we got to create these relationships. I have one of my colleagues here, Magdalena. This is the session that's going to get started. Say hi to our group here.
Hello.
So I'm gonna just stay for the intro and then come back for the Q&A. Yeah. So if you want to stay here, it's up to you. Stay here. Yeah, it's up to you. Hello. So I'll just get another chair. So I'll be back in just a minute. Okay. Just gotta handle some stuff. Thanks, guys. Okay.
Hi, Migena.
Hey.
Hello. Hello. Hi. Was Migena able to share her screen? Is she all set?
Right. So after we start, then basically I'll give her basically the right to share screen. Yeah,
okay, no problem. Do you think you could give me permission to share my screen so I could put up a slide at the end?
Sure.
Yeah.
Okay. Thanks.
Make sure I get my slides in order. There we go.
Okay. Yeah, you should be able to do so.
Oh, yeah, I have the ability to share now. I'm just gonna share just to try it out.
Yeah, go for it.
Yeah. I mean, we have some people who are.
You could just leave that screen up, Migena.
Screen up here. As people log in so they can see this. Okay.
All right. So we have a couple of people who are waiting. Are we good to start allowing people to basically join in?
Yeah, we're only 5 minutes out, right? Do you have any other setups you got to do on your end over there?
Nope, that's all.
All right, so we got the presentation up. So yeah, if you want, you can start letting people in.
All right, let me start. Okay. All right, there we go. Slowly.
Can you guys hear me okay? I didn't ask anybody.
Perfect.
Okay, good.
So I'm just going to mute everybody for now. Okay, now look at this poster.
Hello.
Well, Coach, I hear.
Hey, Nora. Hey, Dr. Chofer.
Hello. Hi. Hi, everyone.
Hi, Nora.
I see some people at work, so I'm not the only one.
So, Coach, I finally got in.
Hey guys, hi Dr. Choshai. Good to see you again.
Good to be seen.
Good to see everyone here. Hi, Ermal. I see you also working, huh?
I think Dr. Bojdani stepped away for a
He's
second.
muted.
Yeah, no,
He's muted. Yeah,
he
yeah.
wait for a couple minutes. He just had to do something, but like he'll be back at the start.
Oh,
Jürgen, how are you?
So far, so good.
Good. Good,
Not
son.
much last time.
Yeah. Okay,
we had
guys,
the
can you
journal
hear me
meeting.
now? Hi.
Yes.
Nora, you hear me?
yeah, I can hear you. I
Good,
can hear
good,
you.
good to
Yeah,
see
yeah,
you.
yeah.
Yeah, I had to step away for a
Hey,
little bit.
Ermal.
Good to see
Okay.
you. Yeah, yeah. Thank you for organizing this. This is Migena,
Oh,
one of my
please.
colleagues. Hello.
Oh, hi. Well,
We're
my
in the
pleasure.
emergency room.
My
Yeah,
pleasure. My pleasure. It's really nice to have you here, and then I'm so glad you're doing this topic. It's useful for everyone. It's going to be very informative. Thank you.
Absolutely, of course, of course.
Yeah, yeah.
So you're also working tonight, I see, huh?
Jürgen is the host because I'm at work, and in case they call me, I'm not going to be able to be
sure,
constantly there. Yeah, yeah,
sure.
yeah.
Great, great. Okay, so I'll mute myself now. All right.
Yeah. So
Okay.
it seems like we have a couple of people joining the last. So we'll give it like another 2 minutes and then we'll start with introductions and then we'll move on from there.
Awesome.
shout out to my sister and my mother. They've joined. Lindita and Flora. Good to see you guys. Where are they? There you go.
Oh, that's awesome.
Yeah, that's
Hi,
amazing.
everyone.
They're big supporters
Hello.
of science and
Hi.
Hey.
Those nice FM support. Nice.
We need all the support we can get from everyone. Hi, Lawrence. You look like you're in the car.
Hey, Nora. I am in the
Hey.
car.
That's awesome.
I'm on the side of the road, so it's okay. I'm not driving.
Oh, okay. That's okay. All right.
All right, we have Blaron.
Hi, Nora. This is
Uh,
Bashkim. Glad to see you guys.
Oh, hi, Bashkim. Thank you for joining us. Wow, awesome. We really gonna have a good discussion.
Hey, Nora, it's Linda.
Oh, hi, Linda. Thank you for joining us.
No problem.
Amazing. All right. We have quite a good group here. Amazing.
Is
Very
that,
nice. Yeah.
is that Bashkim
Yeah.
Kadir?
Yeah,
Yeah.
that's Bash.
Hey, Skill Koshai, nice to see you again.
Thank you.
Bash,
I think it's muted.
Oh, that's all right.
Bashkim.
Don't worry about it. Nice to see you again.
Okay, probably he can't hear. Jürgen, are we still waiting?
Anybody
Oh,
else
you
waiting?
think-
Can we start?
Yeah, give me one second. Let me just make sure. Yep, we're good.
How about we start then? And you know, if
Yeah,
anyone else
fine.
comes in, just add them to the call. How's that?
Yep, that works.
All
Sounds
right.
good.
Well, welcome everyone to our fourth Albanian American Medical Society Journal Club / seminar for the year. You know, it's quite an exciting time, and every time we do this event, more and more people are logging in and joining us. So it's very exciting, and we're thrilled that all of you guys have joined us. I just wanted to take a moment to acknowledge the incredible work that the members of AAMS are doing, including Jürgen and Sarah Kraziu and Nora and everybody else in setting up these events and arranging the logistics, and not just setting up a Zoom link, but getting all our wonderful volunteers to present and share their expertise and their knowledge. And also taking time out of their busy schedule. As you can see, a lot of our presenters and our members who are joining here are in midst of their works in the hospitals or in their labs working. So really appreciate you guys taking the time and joining us for this event. So it's important to acknowledge that effort, and also the fact that you know, these talks matter, and they are they are important topics that affect us all, not just us as healthcare providers and medical people, but also the Albanian community at large. I also want to take a moment to acknowledge the fact that a lot of the people that actually signed up for this talk, and some of the previous ones as well, are coming from many different fields. They're going from not just the clinical side of medicine, but also from outside of medicine too, including students, basic science researchers. We have people from the healthcare industry, and even a healthcare hedge fund manager who is quite an exciting group of people to get together for this 1 hour and share some important information. So without further ado, let me introduce the topic for today's talk. We'll be discussing, or our illustrious presenters, I should say, will be discussing an article that's was published in the Annals of Clinical and Translational Neurology. The topic is persistent neurologic symptoms and cognitive dysfunction in non-hospitalized COVID-19 long haulers. This is about as relevant topic as you can get nowadays, especially with the year that we all went through. So really excited to hear what's going on with with long haulers on COVID, because everybody is hear these words, but it's kind of hard to understand what's really it's evidence-based and what the research is telling us versus what the news is telling us. And we have we have a great presenter today. Dr. Migena Dervishi is a research coordinator at Vanderbilt University Medical Center in the Psychiatry Department with an area of focus in neurocognitive disorders and forensic psychiatry. Wow. Thanks for being with us, Migena and Dr. Dervishi, I'm sorry, and for sharing your knowledge and this topic of this article in particular. And we also have Dr. Ermal Bojdani, who's an attending physician and a board certified psychiatrist at New York Presbyterian Hospital, Columbia University at the Irving Medical Center, as well as a faculty member of Columbia University Vagelos College of Physicians and Surgeons. And Dr. Bojdani is in the midst of working, so we'll excuse him if he needs to step away, but I really appreciate his time to join us today for this talk. And without further ado, we'll have Dr. Dervishi take over.
Hello, everyone. It's nice to virtually meet everybody, and it's such an honor to have the chance to present today at the Journal Club. So thank you, Dr. Malalari, for the introduction. As he said, I am a research coordinator at the Vanderbilt University Medical Center. I'm originally from Albania, but received my medical doctor's degree at the University of Pristina in Kosovo, and have been living here in US for the last few years while I prepare for residency application. Again, it is such an honor to present this case, and it's a very hot topic, as we mentioned, and I'm sure everybody has talked about COVID at least once a day in the past year, and we're hoping we're not going to talk about COVID as much as we did for the last year in the upcoming days, hopefully. So today, I'm going to share here real quick. Hold on one second. My screen stopped. One second. I'm going to share my screen with you guys again. So here we have a presentation. So today we will be talking mainly about the neurologic symptoms and cognitive dysfunctions in non-hospitalized patients with COVID-19 or the long haulers. We're going to start by talking about a few information about the COVID-19, such as etiology and epidemiology, some of the clinical findings in patients with COVID-19. We have a very interesting case presentation that Dr. Bojdani has brought in for this purpose of the Journal Club, and we have the article review. And at the end of the presentation, we have a session dedicated to questions and answers and comments or critiques that everybody might have. You can put them in the chat box and we will answer to them accordingly. So as I mentioned, COVID-19 has been a very hot topic for the last year. So this disease is a contagious infectious disease caused by severe acute respiratory syndrome, coronavirus 2 or SARS-CoV-2. The very first cases were reported in Wuhan, which is a province of China, in the late December of 2019. It progressed very rapidly, and as of March of 2020, it was declared a global pandemic. And ever since, there have been a lot of cases of deaths and infection rates. So to date, there are 3.2 million deaths and 198 million infections recorded worldwide. And despite that, there is no actual knowledge of the current of the COVID-19, based on the genetic analysis, it is suggested that the SARS-CoV-2 probably evolved from a strain that was found in bats. And the coronaviruses are positive stranded RNA viruses. And if you would see them under an electron microscope, they have the appearance of a crown. Hence, they got the name coronum, which in Latin is a term for crown. And this appearance comes from the spike glycoproteins in the envelope of the virus. So this is a table that shows the death rates in different countries of the world. And if we look at this table over here, we can see that the United States had the highest number of deaths worldwide that was followed by Brazil, India, and other countries such as Russia, United Kingdom, Iran, and other countries in the world. Also, United States had the highest number of infections worldwide, unfortunately. Pretty much everybody is prone to getting infected from the COVID-19, but patients who are 60 years and older and patients who have comorbidities such as hypertension, diabetes, obesity, chronic lung disease, cancer, they are at a higher risk for developing severe COVID-19 infection. And it actually has been calculated that the number of hospitalizations from patients with comorbidities was 6 times higher than those with who did not have these comorbidities at the same age. The severity of the infection and mortality related to COVID also is different between different ethnic groups. And it has been shown by other studies that the male patients are at higher risk for developing severe illness compared to female patients. So COVID-19 primarily affects the respiratory system, and it can manifest with symptoms such as cough, sputum production, shortness of breath, fever, but also it's not limited only to the respiratory system. It can affect extrapulmonary organ systems such as musculoskeletal system and presents with myalgia, joint pain, headache, fatigue, and other GI symptoms such as abdominal pain, vomiting, diarrhea, and less commonly presents as a mucocutaneous cluster. It is from studies, it has been shown that the COVID-19 affects organs in different ways, and the dysfunction that is caused to these organ systems can be explained by one or a combination of the following mechanisms, such as direct viral toxicity to those organs, ischemic injury caused by vasculitis, thrombosis, thromboinflammation, immune dysregulation, renin-angiotensin-aldosterone system dysregulation also. From what we have heard from the CDC, there were a few things that we could do to prevent coronavirus infection, to prevent the spread of the coronavirus. Things such as social distancing, protective gear such as masks, gowns, or gloves for those who work in healthcare and had direct patient contact daily. Hand hygiene, this includes antibacterial soap or an alcohol-based hand sanitizer. Vaccines, which fortunately they have been developed in the last few months. And for those who were infected, quarantine was recommended. And the quarantine subject was different at the beginning of the pandemic, where it was recommended that the 14-day was enough to quarantine when somebody had an infection with COVID, but later on that was changed to 10-day quarantine, and no longer was indicated that you have to have a negative test result to return back to work. So these were subject to change. I'm going to spend a little bit of time explaining this table over here that talks about the vaccines. I think this is really important, and this is a really important development who help to stop the spreadness of COVID-19. So there were a few vaccines that have been developed in the last few months, such as the AstraZeneca, Moderna, the Pfizer vaccine, the Sputnik vaccine, the Sinovac, the Johnson & Johnson, which I believe it has resumed its activity. So now it's up again on the market and it's being given to the patients. Out of all these vaccines, most of them, they had 2 dosage that needed to be administered to have full protection for COVID, despite Johnson & Johnson, who only needed 1 dose of the vaccine to be fully protected. Moderna and Pfizer had the highest effectivity rate, 95% and 94% respectively. The only difference between these 2 vaccines was the storage or the handling of it. So the Pfizer vaccine requires minus 70 Celsius refrigeration versus the Moderna, who needs only minus 20 refrigeration storage. So these were a few differences, but again, this is a very good breakthrough, and we're hoping that with the help of the vaccines, we will be able to end this pandemic. Another good news, I think, to share is that as of May 10th, the FDA has authorized usage of the Pfizer vaccine for patients who are 12 years and older. And I believe that there are current trials being developed for children. So hopefully in the future, kids can also have the Pfizer vaccine to prevent this virus. So this was a little bit of the information or introduction about the COVID vaccine. We're going to move on to be talking about a case report that Dr. Bojdani has brought for this presentation. And we're going to be talking about a patient that he saw at the hospital. He saw a 60-year-old female from Albania who resided in New York, and she lives with her son and daughter-in-law there. She did not report any psychiatric history or symptoms before she presented to the hospital. The patient presented to the hospital with symptoms who had lasted for 3 weeks, symptoms such as temperature of 100.5 Fahrenheit, cough, shortness of breath with exertion, oxygen saturation more than 93%. She presented with sneezing, sore throat, lethargy, occasional diarrhea, numbness and tingling on toes and fingers. So there was an initial evaluation for this patient, and everything, that evaluation was normal. So she was discharged home on no therapy at that moment. But 1 week after the initial presentation, the patient presented again to the hospital, and this time she had new symptoms such as frequent panic attacks, which she described as the whole body shaking, palpitation, feeling like having a heart attack, insomnia or difficult to sleep in, and decreased appetite. So at this point, given the new symptoms that have been developed during that week, there were a few differential diagnoses on the list, such as acute psychosis, other psychotic disorders such as panic attack, major depressive disorder with psychotic features or seizure, other viral infections such as influenza A or B, and pneumonia also. The patient was admitted to the hospital at that point, and she was evaluated for about 1 week at the neurology unit. During that time, she had several testing done, such as blood work. She had a head CT, a brain MRI, a psychiatric evaluation. All these tests came back normal and within normal limits. So she was discharged home after a week with instructions to follow up with her primary care doctor as soon as possible and to return to the emergency department or hospital as needed if she had any new symptoms or if those current symptoms worsened. She followed up with a primary care doctor who started her on fluoxetine and benzodiazepines such as alprazolam. 3 weeks after the initial presentation at the primary care doctor, the patient presented again to the hospital, and she reported that her symptoms did not improve, but also this time had other new psychotic symptoms such as visual hallucinations. She reported seeing ghosts and other dead family members. At this time, psychiatry was consulted again, and the decision was made that her treatment plan to be adjusted. So her fluoxetine or SSRI was increased to 40 milligrams, and the benzodiazepine was switched from alprazolam to a long-acting lorazepam, which she took up to 1 milligram by mouth 3 times per day. Also, she had Seroquel added to the treatment plan. The patient then was discharged home after the modification of the treatment plan. And she had a normal physical exam when she went home. She was reevaluated after about 1 month of being on Seroquel. And at that point of time, she reported that her psychotic symptom had resolved. Then the only symptom that was occasionally ongoing was numbness and tingling on her toes and fingers. Otherwise, her psychotic symptoms completely resolved. So this was a very interesting case report, I think, that Dr. Bojdani brought in. And if you guys have any questions more about this, he will answer at the end of the presentation. Since he's the one who saw this patient, he has more input for this. I'm going to be talking about the persistent neurologic and cognitive dysfunction in non-hospitalized COVID-19 patients. This is an article that was published by the Department of Neurology from the Northwestern University Feinberg School of Medicine in Chicago, Illinois. And this is again specifically to review those neurologic and cognitive dysfunctions in these patients. So far, there have been evaluation on this topic about the patients who were hospitalized because of COVID. So it has been reported that 36.4% to 82.3% of these patients have reported a neurologic manifestation at several stages while hospitalized. Not only neurologic symptoms, but there were other symptoms such as pulmonary, cardiac, and gastrointestinal dysfunction who persisted in the post-acute phase, and they constituted to what we call a long COVID syndrome. So the purpose of the study was to characterize the range of these neurologic manifestation in non-hospitalized patients who presented to the Neuro-COVID-19 clinic in both COVID positive laboratory tested patients and the laboratory negative SARS-CoV-2 individuals. So patients who were enrolled in the study met the inclusion criteria, such as they had symptoms of SARS-CoV-2. They had a positive nasopharyngeal test done by PCR and or a SARS-CoV-2 antibody testing. They did not require hospitalization for pneumonia or hypoxemia. They also had neurologic symptoms for 6 weeks from the symptom onset. The exclusion criteria were basically hospitalization for pneumonia or hypoxemia, neurologic symptoms less than 6 weeks. This study, or for the purpose of this study, there were 135 patients evaluated total, but 35 of those patients did not meet eligibility criteria. So the study sample was only 100 patients total. This is a prospective non-blind study, and patients were evaluated at the Neuro-COVID-19 unit at the Northwestern University. So I mentioned earlier, some of them were evaluated in person. So 52 of the patients were seen in person, and 48 of the patients were evaluated through televisits or telemedicine visits. The study recruited patients for about 6 months, starting May 13th of 2020 until November 11th of 2020. The patients were basically 50 with SARS-CoV positive, so the 50 consecutive patients with a positive test and 50 consecutive patients with a negative test for COVID. And then depending on which group they were, they had a different time frame of follow-up. So approximately patients with a positive test were followed up in 4.8 months, and patients with a negative test were followed up in 5.82 months post initial presentation. So in this table here, we can see a little bit of information about the demographics of the patients who were involved in the study. So so we can see that 70% of the patients were female patients and 30% of the patients were male patients. There were not a lot of difference as far as the BMI here. We can see also that some of the patients had pre-existing depression, anxiety disease in the past, or autoimmune disease, or insomnia, or lung disease, or headaches. So these were the most common pre-existing comorbidities that were found in these two groups of patients. All right, 1 second, you guys, my screen just stopped. I'm gonna stop sharing and share again. So sorry, technical difficulties. Apologize for that. All right, we're back. The patients were evaluated by an attending neurologist, a nurse practitioner, a neuro, immunology fellows and neurology residents. The patients were assessed for their cognition and fatigue domains, which the study used different tools such as the PROMIS assessment tool and the Toolbox version 2 instrument from the National Institute of Health. And the components that were assessed from the Toolbox were the processing speed, the attention, the executive memory, executive function, working memory. Besides these assessments, there were also laboratory testing done, such as ANA, erythrosedimentation rate, the ferritin, the D-dimer, the C-reactive protein, etc. And there were a few very limited neuroimaging done, such as brain MRI, but there were just a few of them done. The quality of life measures and the standardized cognitive tests, as I mentioned, there were PROMIS inventory or the PROMIS assessment that was completed by 76% of patients. 37 of those patients had COVID positive test, and 39 of those patients had a COVID negative test. The NIH Toolbox assessment was completed by 36% of the patients, in which group 48% of those had a COVID positive test and 24 had a COVID negative test. The Toolbox T-score was unavailable for 2 SARS-CoV patients, and only 34 of the T-score values were used to be analyzed for the purpose of the study. So the results were expressed in T-scores, basically, that were adjusted for age and components. So on this table, we can see how the PROMIS assessment looked like, or the patient-reported outcome measurement information system. So there are a few questions here that the patients have answered subjectively, and they had for each question basically multiple choice from 1 to 5, with 1 representing a poor performance, or and the 5 being the excellent choice or the excellent performance based on that question. So for example, one of the questions was, please describe how well you carry out your usual social activities and roles. Those just indicates that to what extent this toolbox or this survey assessed the cognition and the fatigue on these patients, or the quality of life. And then the other component, or the other survey, was the NIH Toolbox version 2. This one assessed the executive function, the processing speed, the attention, and the working memory. So from this study, it was shown that 52 patients had a complete neurologic exam, so an in-person exam, and 48 patients had a limited virtual neurologic exam. So overall, 53% had an abnormal neurologic exam. 32% of the patients reported short-term memory deficit, and 27% reported attention deficit. So we can see on this table here the most common symptoms that the patients have reported, with 4 symptoms being the most common, such as brain fog, headache, numbness and tingling, or anosmia or myalgia. Some of the symptoms that the patients reported, such as brain fog or headache, for instance, we can see over here, they did not have, it was not shown a significant difference between the 2 groups. So for example, 43% or 43 patients reported brain fog in the SARS-CoV positive group versus 42 patients reported brain fog in the SARS-CoV negative group. So it was not quite significant, so to speak. And the next symptom, headache, 41 patients reported that in the COVID positive group versus 40 patients in the COVID negative group. But the symptoms that had a significant difference between the 2 groups were anosmia and the blurred vision. So if we can see from this study, 37 patients with COVID positive test, they reported anosmia, compared to 18 patients on the COVID negative group who reported anosmia. And for the blurred vision symptom, 9 patients in the COVID positive group reported that symptom, and 21 in the COVID negative group surprisingly reported that symptom as well. So these were the most common or the most frequent symptoms that the patients reported. As I mentioned in the previous slide, the SARS-CoV positive patients, they were followed up in 4.72 months, and they reported, so 67.8% of them reported subjective recovery impression, compared to the SARS-CoV negative group, who were followed up in 5.82 months, where 60.3% of them reported subjective recovery impression. Besides the neurocognitive test, there were other diagnostic tests done, and the results are expressed in this table. So there were tests such as the ANA or anti-nuclear antibody, the erythrosedimentation rate, the C-reactive protein, D-dimer, and ferritin. Other limited testing, there were brain MRI or spine MRI, EEG, and EMG, but they were not done in a high number of patients, so in just a few sample of patients. The anti-nuclear antibody ratio looks here that it was higher in 3 patients in the SARS-CoV positive group and in 8 in the SARS-CoV negative group. Of these patients, 1 who was in the SARS-CoV in the COVID positive group had a previous history of immunologic disorder. So that is for the anti-nuclear antibody ratio. And the other testing, such as the ESR, the C-reactive protein, D-dimer, or the ferritin, did not have any significant difference between the 2 groups. On this other table, they are the T-scores expressed for the PROMIS testing and the NIH toolbox. So these T-scores were adjusted for age, education, gender, race, and ethnicity. The median score of 50 and with a standard deviation of 10. The lower cognition T-scores indicated worse cognitive performance, and the higher fatigue T-scores indicated greater fatigue severity. So if we can see here on this table, basically the cognition T-score was 38 in the COVID positive group compared to 33 in the COVID negative group. And also the T-score for the fatigue was 64 and 69 in the COVID negative group. Oops, looks like somebody is drawing on my slide, but that's okay. And here we have a table. We have 2 tables who report the recovery or subjective recovery report based on what patients declared. So the table A is the table for the SARS-CoV positive group, and the table B report is for the SARS-CoV negative group. So it looks like, based on the R score here expressed, there is no significant difference between the time onset of the symptoms and the recovery from what the patients have reported. All right, I'm going to have to erase this beautiful drawing that is here on my slide real quick. So give me a second. I'm not sure where that came from, but it's gone now. There were a few limitations for the study. The study sample size was not as high as, to evaluate a lot of patients in the study. There were only 100 patients evaluated, and the time frame was only 6 months. So it was not a long duration to evaluate patients for a long time. Patient evaluation was also another limitation because some of the patients could not come into the clinic. So most of the visits were done remotely, and that just, have another limitation there because you cannot assess the patients basically in person. The testing at the beginning of the pandemic was very limited because there were not enough testing out there in the market. So some of the patients did not have testing done, or they had to wait for the test results. The cognitive status report was assessed by the patient. So this was just a subjective cognitive status report by them. And also the providers or the doctors did not have any pre-COVID-19 quality of life and cognitive assessment to compare with what the patient reported after they were seen at the hospital. So it was just assumed that the baseline pre-COVID was 100%, and there was no data to compare that with the previous, medical history in these patients. And my screen froze again, so I'm so sorry, guys. I'm gonna have to stop sharing and reshare again. I apologize for that. All right, so this is a conclusion about this study. So basically, from what we know now is that the neurologic symptoms post-COVID-19, they are the most common ones are the brain fog, the headache, the numbness and tingling, dysgeusia, anosmia, myalgia, dizziness, pain or blurred vision, and tinnitus. There were also an increased female to male ratio and comorbidities that suggested autoimmune etiology. Other mechanisms that may be contributing to long COVID-19 symptoms are such as post-infectious or autoimmune disorders, a similarity to chronic fatigue symptoms with the neurologic symptoms post-COVID, the impact on the quality of life that these neurologic symptoms had on these patients, such as loss of productivity of these patients in different life fields, such as at work or at home. And then in conclusion, we can say that further studies need to be done to elucidate the pathogenesis of the SARS-CoV-2 in the nervous system, so we can better understand how COVID-19 affects the nervous system and reflects with presentation of these symptoms that we just spoke about. So thank you again for listening to me, and this was the article review. And thank you, Dr. Bojdani, for bringing in this interesting article and the case report for a patient that he saw. And I believe the floor now is open to question and answers with hopes that we can answer to everybody.
That was great, Dr. Dervishi. Thank you so much for presenting the article. Very interesting stuff. We learned about COVID as we went along last year, all of us really. I don't think many of us were aware of the possibility of a respiratory infection causing this type of, cognitive or neurological issues. SARS was going on in Asia a few years back. It's CoV-1 when it first started. But I don't remember any reports of those patients having significant neurological symptoms, maybe because there was a lower, number of patients that got infected at the time compared to the hundreds of millions that got COVID-2 or COVID-19. I guess one question I brought on, and I'm a surgeon myself, so I'm obviously not as, familiar with some of the neurological and psychiatric presentations, but this term of brain fog, has this been used in that field previously? Has it been associated with other neurological disorders or psychiatric disorders, or is it termed specifically to COVID-19 as a symptom to encompass this this issue with cognitive dysfunction? And the reason why I bring that up is because there's quite a few articles that even in the news media about people that are in pretty high stress type positions, including doctors, who get COVID-19 and then they're unable to work because of the quote unquote brain fog that they have. They're unable to focus and concentrate. So I was wondering if this term of brain fog is fairly new and it's been labeled for COVID-19 patients, or is there other neurological issues or conditions that have been used in the past? Because I've never heard of it before.
Well, being an old man and an old surgeon.
You're not that old, Dr. Chaushay.
But as an old professor, I can tell you, we used to call patients who spent a lot of time on the extracorporeal oxygenator for open heart surgery, and they would be called pump heads. So brain fog is not a new phenomenon.
Good to know.
Maybe it's more like a generalization of a lot of symptoms together, such as like mental, like slowing down or just feeling fuzzy or spaced out, something like that, in conjunction with other psychiatric disorders such as depression, when patients report that slowing, so slow. So maybe it's just a generalization.
Could be.
My opinion.
I would also like to make another comment. I think that the quality of your presentation was outstanding, and I'd like to thank you for your effort that you put into making such a clear and cogent presentation.
Thank you. It means a lot coming from you.
It wasn't an easy article either.
Yeah. Migena, this is Bashkim Kadrio. So thank you so much. I agree with Dr. Chaushay. This was really interesting presentation. So let me just, I think I want to make 2 points regarding the sort of the brain fog, the phenomenology, and but also what struck me is when you presented the study, around 40% of your patient, 45, I think, % of your patient had a comorbid anxiety and depression disorder. And anxiety actually and depression both can cause what we call long-term cognitive impairment, symptoms which are associated with cognitive dysfunction and executive functioning impairment. What's interesting is that when you add to that, what people I think oftentimes don't understand very well is that, if you have a depression or anxiety, actually, or in general, psychiatric disorder can make you more prone to immune-based disorders. What we find in our studies, especially, I just left NIH a few months back, but a third of patients who have severe depression or anxiety actually have what we call an immune or a heightened state of inflammatory tone. And when you add into that a symptoms of COVID-19, which is this sort of aspect of fulminant or cytokine storm that sort of impairs body immune system, it can add further to the worsening of depression and anxiety, but on top of that can even impair further the cognitive symptoms. And I think the brain fog is part of that, is sort of this long-term sequelae of executive dysfunction that people have experienced. The other aspect.
Can I ask you a question at this point?
Yeah.
Because you made that statement as though it applies. When we care for these patients in the ICU at our hospital, many of these patients also have a thrombotic phenomenon, a thrombophlebitis, a vasculitis, and all of these could be contributing factors even in a non-depressed individual.
Absolutely. Dr. Chaushay, like when I was part of NIH, and I'm still indirectly part of it because having still a associate position, I remember Dr. Fauci used to give this fire chat with Francis Collins on a weekly basis as the COVID-19 situation was evolving. And I think even the scientific community was surprised by the scope of the various neurological and psychiatric, but also medical, problems. The SARS-CoV-19 was expressed. And I think the other aspect that I want to point out, and this may be familiar to Dr. Chaushay and surgeons here, oftentimes the patients presented with acute delirium symptoms, which the patient, what that Dr. Bojdani brought here, it brings me sort of, it kind of rings the tone of somebody who is like acutely delirious or in a state of pre-delirious state. And I think oftentimes SARS-CoV-19 didn't use these kind of symptoms transiently, and it's often very easy to misdiagnose this individual as psychotic individual when in fact, they're having just their brain is overwhelmed by the immune reaction, or like the cytokine storm that is overwhelming the body.
Yeah.
Hello.
Great explanation.
Hey. Hi. Migena, thank you for the presentation. That was great. Really nice presentation and great topic. Bashkin, since we have you here as a psychiatrist, and Ermal, I guess he's busy right now, I have a question. So I notice a lot of my patients, I know this is different from, outpatient setting, but a lot of patients have anxiety, panic attack, and fear of dying constantly. They just have chest pain, shortness of breath. And that point, really, oxygen saturation goes down immediately. Yeah. And I am assured that sometimes they get even intubated because they can't even breathe. Yeah. So I think that this is just like in the acute setting in hospital, but this has been happening a lot. So my question is like, how long this can go on? And what are the sequelae of all this anxiety and panic attacks that happens with COVID patients?
Well, I think, listen, like one of the really most difficult aspect of seeing patient, treating patient during this period of time was, when somebody with anxiety or panic disorders comes to your office, you often try to explain them how this is all a sort of a construct, a cognitive construct in your mind that gradually sort of overwhelms your body. So it starts as a sort of a cognitive distortion, what we call, and gradually this erroneous signal becomes, signal enough for them that it overwhelms them. So the idea, as a psychiatrist, you're trying to kind of discern that and put in the cognitive aspect, say, hey, this is how anxiety overwhelms you. Like if you still, you're overwhelming yourself with this thought, then gradually becomes somatic and overwhelms your body. What happened is, when SARS-CoV-19 hit, these individuals who thought, especially anxious patients who think world is dangerous place, they get just, we had no argument to tell them that the world was not a dangerous place. It wasn't very unpredictable place. And as a result, it added further into their anxiety and panic symptoms. And I can tell you, like, the panic is, I explain this to engineers easily, or, when you remember those old radios, the radio frequency is like, 90% of it is sort of, noise, and, small percentage is signal when you are in real signal. However, the individuals with anxiety and panic, they perceive this noise, which for us, we filter out on daily basis as signal, and that's what overwhelms them. And if you sort of are in constant verge of living under anxiety, that drains significant amount of body energy. Brain on regular basis drains about, or spends about 20 to 30% of body energy, and it's the glucose metabolism, because that's, it takes a lot of energy to have all these neurons function. But when these individuals are on constant verge of feeling anxious, believe me, it drains a substantial amount of their energy, and that's why they're always in the verge of breakdown.
I love this. I mean, forgive me, I'm a surgeon, and so I have no anxiety. And but when I listen to you speak, this can't explain all of the phenomenon that we see it. As Anthony Fauci has said several times, we don't know what's going on. We don't understand the relationship of the vasculitis with the psychological, physical. and it's the whole body. I mean, people are anxious, but you know, they don't become long haulers because of that. They become long haulers because some insult affects their brain, and we don't know what that insult is.
No, absolutely, Dr. Chowshay. I mean, this is a mixed of, you know, combination of many things. But I think I see things from a brain standpoint.
I'm anxious too, so I'm sorry. I'm going to speak to my therapist after this is done. I'm joking.
You know, and Dr. Chowshay is really is right. And the other thing that, you know, it's interesting with these patients is even the ones who were not very sick from COVID, the ones who, you know, recovered at home or were asymptomatic, will get this, right? So something else is going on that we just don't know.
Or the patients that get anosmia can't smell and it never comes back. One of my colleagues, she's fine mentally, she just can't smell anymore.
You know, another aspect of this was, you know, like the anosmia is a very interesting phenomenology because, you know, the olfactory bulb is the closest proximity of the sort of the barrier with the blood-brain barrier. And I think also that's a path of, you know, how our brain is get also impacted. I think it's through, you know, afferents and but olfactory bulb can be interesting.
So,
Raskin, when you can get two surgeons to argue with you, it's a good day.
No, that definitely made my day.
Excellent. Excellent.
We're kind of out of our field here.
If Sarah Criazillo could come join the conversation, I would be even happier because that would be three surgeons. It'd be three surgeons. All right.
Great job, Migena. That was wonderful. That was a great presentation. I really enjoyed it. It was a tough article. I see a few questions in the chat that I'd like to bring up and comments. Gerta asked about the patient's course. I'm not sure if you'll know the full extent of the treatment, but she asked whether the patient continued on SSRI or on the Seroquel after the initial psychosis had ended. I think the answer is no, but I guess we'll wait for Dr. Bojdani to come back.
Yes, I would be more comfortable if Dr. Bojdani answers that since he was the one to follow up with the patient, and I am not 100% sure of that answer, so we will be answering to you shortly. But I see Dr. Bojdani has posted also another interesting topic regarding, you know, the social distancing that we have been doing during this time to prevent COVID and how that affects people who don't necessarily have COVID, but they're, you know, just social distancing or isolating or even working from home, how that affected our psychology and, you know, mental health. And I think not only affected, but now that things are opening back up, how, you know, how has that made us feel now? How comfortable are we going back, knowing what we know now? So I think that's another strain that we need, maybe in another journal club, we will review that, how people will react to going back to where we were before 2019, back to handshakes and, you know, meeting and hugging.
Right.
So,
you know, I don't think we will go back to complete normalcy. If you look at Asia, which has suffered more SARS epidemics than we have, if you go to Japan, they wear 25% of the population wears masks everywhere.
Yeah.
And they wear gloves everywhere. China is the same way, and I've been to both countries extensively. They will not. And you know, if you're going to be on a subway in New York City, you might want to wear a mask. You might even want to wear gloves. You know, besides everything else you wear. So it's you know, you think about it.
Yeah.
This week, Tennessee announced that, you know, we will open back up where I live now, and there was a video circulating on social media how the Broadway and the honky tonks were back on, and you know, everybody was in full mood going back in downtown in the city. So that's quite interesting.
Excellent. It may reduce the Trump vote next time.
It's another way to look at it.
We're not gonna endorse any
There's always something
candidates here.
positive. Something positive comes out of everything.
You know what, Dr. Chausha, since you've been traveling in Asia a lot, what do you think the whole wearing a mask on a daily basis? Do you think it's more cultural or mostly because of all the infections they've had?
Hey, think about this. I didn't get the flu this year.
True.
And our hospital flu admission rates have plummeted. The mask actually does do something. And, you know, we don't want to think about it, but, you know, we all get viral syndromes and things that the common flu kills 50,000 Americans every year.
Yeah.
Do we want to wear masks?
Zero flu patients this year. Yeah. It was unbelievable. We had 0 patients.
And I like wearing a mask. This way you can tell somebody they're a jackass and they don't even see your mouth moving.
There's some benefits to it, I guess, huh?
It's also a professional.
I see we got Dr. Bojdani back.
He was like,
Bashki might need therapy. I know this. I know you.
Dr. Chausha is also a professional defect. You like to feel surgeon everywhere. Right?
You got that right. You got that right.
Dr. Bojdani, I think you're muted if you're trying to speak.
No, I wasn't. I was just saying hi. I was just taking care of a patient, so I'm back. I'm just looking at some of these questions so I can see, in regards to the case, is the patient required to take SSRI and benzo for the psychotic symptoms to be prevented to occur again, or would the patient be able to stop the medication? So I think the way I'd like you guys to think about this is that this is sort of like a post-COVID syndrome that has both psychiatric and neurologic components. And significant symptoms included depression, anxiety with panic attacks, and psychosis. So the SSRIs and the benzos are targeting the depression and the anxiety, and the Seroquel, the antipsychotic, was trying to target her vision of seeing dead people and the psychosis. So the goal is, of course, because these are sort of an entity that we're still trying to make sense of, and I'm still following the patient in outpatient care. The goal is to eventually, as these symptoms resolve, we would want to think about then eventually getting patients off of this and seeing how they do without the medications. But right now, those meds have helped significantly. And so, you know, so at this moment, the patient is still on them. And then let me see, do we have any data about how long does the brain fog last in the long haulers on average? What can we do to help patients get through it? So one of the reasons I picked this article for us was that the New York Times had written a piece and highlighted it. And some of the concerns that people had talked about was that the brain fog for some people, it lasts days, weeks, and even months. And so that's why it's so crucial for sort of people, you know, in this particular clinic, you know, they could get follow-up care, but also to see their primary care, neurology, and psychiatry to make sure that, you know, we're able to see some sort of baseline, whatever it is, and then track the progress in terms of symptoms and whether other interventions are needed. So all great questions.
Dr. Bojdani, if I may, as far as the whole duration of treatment part of this is, do you guys feel that this is going to be more of a long-term management of, you know, not just the brain fog, but also some of the other cognitive issues, almost like you're treating diabetes, so you need to take something to manage it long-term? Or do you think this is more of a symptom that, you know, once the body, I guess, whatever recovers from the insult, you would expect some, especially in patients who have not had, you know, psychiatric symptoms or diagnosis in the past, it's pretty unusual to get, you know, psychosis in their 50s with, you know, without an insult, you know, that you can find, I guess, in the brain. But what's your take on that?
Right, Laurent, exactly, right? So we wouldn't expect new onset psychosis in an elderly patient. And that's why, you know, the brain imaging and stuff is going to help to rule out, you know, some sort of cancer or other sort of conditions that may lead to this. And of course, you know, in the differential with these shaking episodes, of course, we were thinking, could this, you know, be a seizure? And of course, thankfully, sort of neurology had cleared, and they didn't think that there was any sort of significant neurologic syndrome or symptom to keep the patient in the hospital. I think the best answer, Lawrence, is time will tell. Okay, right now, a lot of the patients I see either in the emergency room, inpatient or outpatient, of course, there is sort of the COVID isolation, that has led to people feeling more depressed and sort of more anxious and sort of, upended their life. So that's almost always something I see every day. But sort of this phenomenon, to have the patient experience this cluster of symptoms after they had mild COVID then they were not hospitalized. This is going to have to, be tracked and on an individual basis. And so, for me, all I can say is that with this particular patient, there was worry from her and the family about the symptoms coming back. And of course, the concern about, can you leave this patient alone? I mean, sometimes the thoughts, right, we're sort of getting to that, like, life is not worth living. So part of treatment includes having someone be there with a patient during the day. And we talked about medication, but we know, for example, that other interventions like eating healthy and taking walks outside in fresh air can help. And so that is also part of what I recommended for this being inpatient. And she told me that she had been engaging in physical activity and that sort of thing. So I think I'm hopeful that, maybe these symptoms are going to be sort of 3 to 6 month type thing. And then we can taper the medication and see how they do. And partly it's going to be based on patient preference. I mean, as you all know, when patients start feeling better, what do? You prescribe them a course of antibiotics. Do they complete the course? No, right? So this is eventually what's going to happen down the road. But again, they have to start feeling better first before they do that. Yeah.
Of course.
Ermal, I have a question for you. What is
good to see you?
Yeah, good to see you,
We've seen
Ermal.
each other on chats and on Facebook.
Well, we're seeing each other live now, but yeah, happy to talk to you.
Likewise.
What do you? I think Ermal, I worked in New York and saw a couple of Albanian patients in the past. I think you also have to keep always in mind that, we as community, we don't normalize psychiatric diseases, or we don't seek care for psychiatric disease in general. I think I would, and I'm sure you've done that already, I would really look thoroughly in previous medical history of the individual, because it's possible that these individuals may have had micropsychotic episodes throughout the life. And now, because of SARS-CoV-19, there's more sort of acceptable normalization of the disorder, and the cultural aspect has allowed that to seek medical care. And especially in this case, you're also Albanian physician. So, you got to be very cautious, because it can be, a case of a chronic psychotic case that now is coming to seek care for first time. But it's possible that the disease been there for a long period of time. I can't exclude the fact, I haven't seen the patient, I can exclude the fact that this is a first time psychotic break. And as you know, is like the sort of adherence to treatment is really important if you don't want this to become a long-term sequelae.
And wait, hang on a second there. Albanians have lots of psychiatric illnesses, but we don't necessarily see dead people. So if she had been seeing dead people throughout her life, maybe someone would have said something.
Yeah, especially she lives with her son and her daughter-in-law and nephew, right?
Yeah, I agree, Dr. Chamusha, but believe me, I haven't had the experience so I graduated medicine in Kosovo. And believe me or not, in Kosovo after the war, we had psychiatric hospitals full of patients. And patients would come with a psychosis of 20 years and saying, I have PTSD. Because all of a sudden, PTSD became normalized for society. So in a
Yeah.
society that
I get
hit
that.
by
I get it. I went to Hopkins. I understand. I get it. I get it.
So guys,
He knows PTSD well.
the update on this patient. So for this patient, I mean, I'll say that everything that you guys said is correct, and I'll add to it. So the good news for this patient is that these psychotic symptoms were transient. The low dose Seroquel likely did something for those symptoms, but probably not much. And they resolved completely. So if this was some sort of chronic condition, et cetera, I would not expect resolution of symptoms that quickly or for them to be not as bothersome. So all of that is relevant, but thankfully for this patient, psychosis resolved, and we're saying that it was in the context of this post-COVID experience. Yeah.
And Dr. Bojdani, Sarah is asking a question on the chat over there. And it's actually, I think it's a very good question. Should we be screening patients for depressive symptoms and have it as a, kind of as a important part of the evaluation for, especially for the ones where we know they either got COVID or they were exposed to COVID or were treated for COVID, to kind of try and maybe pick up some of these issues before they get to the psychosis part, or they get, so severe that they need hospitalization for it?
Yeah, I mean, what I would say is that because sort of the pandemic and sort of the recommendations have been ever evolving, I haven't yet seen any guidelines that sort of suggest for either or, but common sense would tell you that we're obviously, all of us, not just patients, but healthcare workers and whatever, are experiencing traumatic events as, we're dealing through the pandemic. So it would make logical sense to do some sort of screening. Of course, the question is going to be, what are you going to use for screening? Who's going to do the screening? Does the clinic that you go to have enough resources to even follow up if there's screen test positive? And so, I think those are some of the things. Probably if you're thinking about who's going to screen, primary care, right, would be ideal. But the thing is, what does primary care say? I'm overworked, I don't have enough time, or the 10 things that patients ask me about when they come in. So the thing is, you do want to be mindful though, and think about that. So yeah, I think if one has the time, then it would be something to think about in this case. Yeah.
And I remember the PHQ-9 or PHQ-2 being used a lot in primary care when I was a med student. So I wonder if we should be implementing it more.
Yeah, so I think, again, it's going to be, there are a lot of technical issues with sort of making a recommendation and then how the clinic is going to carry it out. So all I would say is that if done appropriately, the PHQ-2 or the PHQ-9 would be appropriate screening tools if, if one had the time and could provide appropriate follow-up.
Right. And talking about, what's going on with our, with our profession and our colleagues here, the amount of stress that physicians and nurses and, healthcare workers have been dealing really for the past year, it's significant. And I have, friends who decided to leave medicine because of what what they went through this past, this past year, that just, didn't feel it was worth the amount of stress that they were under, and the anxiety and the risk that they were taking with their families. And I'm sure that's not news to anybody that has worked in a hospital or in a healthcare facilities this past year. Because we obviously have to make sure that we take care of our patients and our community, but we also have to think about ourselves and our colleagues in the in our clinics and in our hospitals, and make sure that and as Dr. Bojdani said, maybe we should be a little bit more aware about what's going on and trying to pick up patients or colleagues who are having a bit of a harder time than usual to help them seek help.
We could end on that very positive note.
All right, I think we're just past the hour. I don't see any other questions on the chat over there. I just wanted to thank again Dr. Dervishi for a wonderful presentation and on a very difficult article, but a very timely topic. And Dr. Bojdani for that case presentation, taking his time out of his busy schedule over there to join us today. Thanks for everyone to that took the time to join the chat. We're going to have more journal clubs and seminars coming up. Please keep an eye on our website and LinkedIn page and Facebook page. We'll keep posting information as the topics and the presenters get finalized. And please share any comments or any feedback as far as what topics you guys like to see presented. We're trying to be as thorough and as as open as possible, different topics and fields, because they're all relevant. And the more feedback we get from you guys, the more relevant and the better those presentations are going to be. So thanks, Dr. Chauskas, for always being with us and supporting our endeavors. It's really wonderful.
Thank you. Good night, everybody.
Bye, everyone.
Thank you, everyone.
Bye.
Have a good night.
Bye.
Good night, everyone.